Welcome to The Explainer. Today, we're diving deep into the clinical realities of acute cholecystitis. We're going to move past the textbook basics and really get into the weeds on the crucial decision-making that goes into diagnosis, microbiological workup, and of course, management.
So here's our game plan. We'll start with the disease itself, then move into identifying the culprits, talk treatment, prevention, and potential complications. And we'll wrap it all up with a quick review to make sure it all sticks.
All right, let's kick things off with the clinical presentation. Getting the diagnosis right begins with having a crystal clear picture of the condition and knowing exactly what signs to look for.
At its very core, cholecystitis is all about inflammation. It's not just about having gallstones. Lots of people have those with no problems. The real issue starts when a stone blocks the cystic duct. That blockage traps the bile, pressure builds up, and that triggers a major inflammatory cascade. That's the engine driving the whole clinical picture we see.
So what are we looking for? It's a specific constellation of signs, a kind of toxidrome. You're searching for that classic triad: sharp pain in the upper right part of the belly, signs of a body-wide inflammation like a fever, and tenderness right over the area. And notice some of the other clues here. Like persistent leakage from a surgical wound, that's a huge red flag for a lingering infection. And that rare mention of giardia, it's a great reminder that while a blockage is the usual suspect, we always have to keep our minds open to other causes, like parasites.
Okay, so once we have a strong clinical suspicion, our focus has to pivot to the microbiology. We need to unmask the pathogens responsible because that's what's going to guide our initial antibiotic choices and eventually our definitive treatment.
The good news is the microbiology here is pretty predictable, and it makes perfect sense when you think about it. The main culprits are the gut bacteria that have made their way up from the duodenum. As you can see, the big one by far is E. coli. After that, you've got your anaerobes and then Enterococcus. This predictable cast of characters is exactly why we can build effective empiric antibiotic regimens from the get-go.
Now, getting an accurate ID on these bugs is all about meticulous sample collection. It's everything. Inoculating blood cultures right there at the bedside isn't just a nice to do, it is absolutely critical to get the best yield and avoid contamination. And for ascites fluid, which can be a big factor in some patients, using the right kind of transport vial is key to keeping those fragile anaerobic bacteria alive for an accurate gram stain.
And all that microbial detective work feeds directly into our therapeutic management. The strategy really boils down to a balancing act: source control, which usually means surgery, and the right antimicrobial therapy, all stratified by how sick the patient is and whether they're even a candidate for surgery.
For that severely ill patient, the one who just can't go to the OR, antibiotics become the main event. And this specific regimen, amoxicillin, metronidazole, and gentamicin, is the go-to. It's a triple threat that provides broad, powerful coverage. Each drug has a job. Amoxicillin hits the enterococci, metronidazole takes care of the anaerobes, and gentamicin handles the gram-negatives like our old friend E. coli.
Now, here is a crucial clinical pearl, especially when you're using aminoglycosides like gentamicin. You have to think about pharmacokinetics. Gentamicin is a water-loving drug, so in a patient with a lot of ascites fluid, its volume of distribution just explodes. If you use standard weight-based dosing, you're going to end up with uselessly low drug levels. That's why you have to give an additional loading dose, about 10 milligrams for every liter of ascites you estimate, to make sure you hit a high enough peak to actually kill the bacteria.
Okay, after that deep dive into pharmacokinetics, let's take a quick mental break with a little microbiology humor.
I know. All right, let's get back to it. This slide really brings into focus the two fundamentally different tracks for management. For most patients, a cholecystectomy is the definitive answer. It gets the source of the infection out. Antibiotics are just there to help out. But for that inoperable patient, the paradigm gets flipped on its head. Antibiotics become the primary therapy. And you see a similar principle in kids with intra-abdominal infections, though the specific drugs might change to something like cefuroxime plus gentamicin based on local resistance patterns. So let's shift gears now and talk about prevention. The idea here is to stop an infection before it even starts. This is especially important in certain high-risk surgical situations where we might use prophylactic antibiotics. The key takeaway here is that prophylaxis is not for everyone. We reserve it for these specific high-risk scenarios.
It's standard for an open cholecystectomy, for instance, because there's just more tissue manipulation. It's also used for high-risk laparoscopic cases, especially when there's already acute inflammation. The common thread in all these situations? A much higher chance of spilling bacteria-filled bile during the procedure.
And we have to be this diligent because if treatment fails, if we don't get source control, the potential complications are severe and potentially life-threatening.
This is what we're all fighting to prevent, the progression to sepsis and septic shock. This is when bacteria and their toxins escape the gallbladder and get into the bloodstream, triggering a massive body-wide inflammatory response. It's a cascade that can lead to organ failure, dangerously low blood pressure, and all the metabolic chaos of septic shock. It really highlights why acting early and effectively is so critical.
Okay, we have covered a ton of information. To make sure we've got it all locked in, let's wrap up with a quick knowledge check.
This quote really is the whole ballgame. It encapsulates the #1 decision point. The first question you have to ask yourself when you see a patient with suspected cholecystitis is, how sick are they? The answer to that question dictates absolutely everything that follows.
First question for you. What is that recommended go-to antibiotic regimen for a patient who is severely ill with acute cholecystitis and is not a candidate for surgery?
That's right. It's amoxicillin, metronidazole, and gentamicin. This combination gives you that comprehensive, synergistic coverage against all the likely culprits: gram-negatives, anaerobes, and enterococcus.
All right, second question. In what situation is it a primary indication to give prophylactic antibiotics during a laparoscopic cholecystectomy?
Exactly. The diagnosis of acute cholecystitis itself is the indication. That active inflammation is a huge signal that the bile is likely to be infected, which totally justifies using prophylactic antibiotics to prevent any complications if there's a spill during the operation.
And let's end on a final thought to take with you. The protocols we've laid out today are based on the antibiotic susceptibility we see right now. But as we all know, resistance patterns are constantly evolving. So the real question is, how will we be forced to adapt these regimens in the future? It's a constant chess match, and staying ahead of it is truly the central challenge in managing infectious diseases today. Thanks for joining this explainer.